So do you want to share your slides, Merva? Are we waiting for people to join?
Yeah, good evening, everybody. I think we have a few folks who've already joined. Maybe we give a minute for a couple more. I know some of them were scrambling to find the right link. Maybe Alia, if you can resend it to some of them.
Sure, doctor. This is what the team is doing now.
Thank you. And if you want us to go ahead and start, I can start so that we get plenty of time for discussion and case reviews. So good afternoon, everybody. Last episode was meant to be the basis for what we're doing and the evidence for it. And kind of moving forward, we want the next 2 episodes to be very practical. So please just raise your hands so that it can be more engaging. I'm going to go ahead and start, and I think you can all see my slides, yeah? Okay. So what I'm going to do is we're trying to focus on calcified lesions today. So if you remember from last time, we said MLD, which is morphology, length, and diameter. And this is what we do pre-imaging. And so our focus is when you do see a calcified lesion to try to assess all of these. So it's not enough that when we see calcium, we say, oh, this is calcium. We need to actually quantify the calcium. We need to describe it, and because it has implications in terms of management. So the first top left is really superficial calcium. So that's what you're seeing. You're seeing some superficial calcium. The second one is actually much deeper. You see the lumen. You see the lumen very clearly, and you see the intima and so on. The calcium is beyond that. Then you have nodular calcium on the right-hand side, where you see that the calcium is actually encroaching on the new lumen. Then, besides superficial, deep, and nodular, you want to know, is it eccentric or is it concentric? So the bottom right is actually a more concentric, that's almost 360. And eccentric, it's limited, and that particular one is from 9 to 12 o'clock. So that's what we need to be doing it. So those were OCT images. Just remember, there's always angiography and there's always IVUS. There are limitations, of course, of angiography, where you can't really look at the arc and the calcium and the thickness and whether it's superficial and deep and so on. Intravascular ultrasound, the main limitation here is thickness and figuring out the thickness, and that's the strength really of OCT in evaluating calcified lesions. So let's look at these together, and please feel free to either raise your hand or unmute yourselves. So what do you see here in the top panel, or the left top panel? So it's calcium, right? So you see the bright shadow. Can you see my pointer, my cursor?
Yes, we can, yeah.
You see around 4 or 5 o'clock, you see the bright shadow, and then you see that we lose acoustic shadowing beyond it. So you know that that's very limited eccentric calcium. And then below it is the paired image with OCT, where you see the calcium exactly in the same place, and you see exactly the thickness of the calcium and how far deep it is. You look at the next one. Can anybody tell me what it looks like? So this is, again, calcified lesions. You see they're quite superficial on the OCT image. And the middle image, you see more concentric calcium that's actually going from 12 o'clock all the way backwards to around 2 o'clock. And again, you see pretty much the same thing on optical coherence tomography. The next image, you start to see the beginning of a nodule forming, and it's beginning to bob into and encroach on the lumen. And I'm just going to keep moving on. Again, this is a really nice paper. You look at it over here. So what you do want to be looking at is exactly what I just showed you a few minutes ago. You're looking at the calcium and it's whether the arc of the calcium, and you're looking at eccentricity and concentricity, like concentric before, but you're also looking at whether it is deep or superficial and its thickness, like the bottom slide number F. So when you look at the intravascular ultrasound, these are paired images again. When you're looking at the acoustic shadow and you're trying to assess the arc and you're trying to assess the thickness, you know, it's covered over here, but this is reverberations. Do you know what reverberations usually mean? Anybody? Is there anyone from the attendees that know what reverberations mean when you look at them on intravascular? Okay.
No, that Adele Al-Gublan has got hand up.
Please go ahead, Adil. Just unmute yourself if you can. Or folks, can you unmute him?
We can just open up everyone's microphone so they can unmute when they need to.
Can we open the mics, everyone? Because we really want it to be interactive, please. Adil, go ahead if you're able to unmute yourself. And can we? Right, a little bit of technical difficulties. Can you type what you want until they figure it out, do you think? Guys,
Doctors, you can access and you can just unmute your mics. It is open for everyone.
so it is superficial calcium, and that is what he's typing it. But you can actually unmute yourself. I think if you click on the microphone, it allows you to unmute yourself. Right. So again, as I said, it's very important that you actually quantify the calcium. So there are different scores, right? Where you're going to look at the angle, the thickness, and the length. So there's the general rule of 5. So you're looking at a thickness of more than 0.5, an arc that's more than 50%, and you're looking at the length. So it's not enough to say that this is a very focal lesion in the vessel. He couldn't unmute himself. So you don't want to say that it's a very short segment. If it's long, your plan may be different in terms of atherectomy. So again, when you're looking at this particular example over here, you're seeing the calcium arc is about 264 degrees. The depth is actually 0.6 to almost 0.7. And the length, when you look at the longitudinal, is about 11 millimeters. The next one is a more concentric calcification again. So these are, the Ultron is giving you the option of having, it actually can give you it, and you look at the orange over here and it'll tell you 280 degrees, the depth is 0.8, so it's very automated. This is a lovely example where you're seeing the depth of the calcium is quite deep, it's 1.2. You're looking at the arc about 100, more than 180 degrees, and it's quite eccentric. And likewise, in the last one over here, you're seeing a nodule and you're seeing spicules that come out of it. And I'm going to momentarily show you a little bit more, I'm sorry, I'm just trying to see if I'm missing anything, but I guess I'll leave it to you, Tom. The other reason, as I said, is you want to see, can you do direct stenting? So really look at this slide very carefully. I'm happy to share it again with you. You need to be able to distinguish in morphology between lipidic, fibrotic, often it's going to be mixed plaque, and then something like deep calcium. Do you see this where my cursor is? This is quite deep. It's not superficial. It's not close to the lumen. Then you look at this. This is neoatherosclerosis, meaning there's a stent and there's growth before the stent or in front of the stent. And then you're looking here at superficial calcium. So compare this one, superficial calcium, where it's very close to the lumen, as opposed to something that is deeper like this one. And then, of course, the nodular again. And as you're moving across the spectrum, you're starting to look at more and more aggressive atherectomy rather than just plain old balloon angioplasty. So you're starting to look at some of your tools that we currently have, whether it is laser, whether it is intravascular lithotripsy, orbital, or rotational atherectomy. So again, you look at this middle one, for example, you see more than 180-degree arc of calcium. The thickness is certainly more than 0.5, and the length in that particular vessel, which you don't see here because I'm not showing you the length, the longitudinal view. And when you look at it in terms of IVUS, it's almost the same thing. So you are going to look at the arc, you are going to look at the length of the lesion, and if you can, likely it's going to be slightly thicker than what you saw previously. And again, this is more nodular over here where the asterisk is. These are the different scoring systems for intravascular ultrasound. Again, you look at the score. If it's 2, 3, or 4, you want to consider atherectomy. If it's less than that, perhaps you can balloon dilate. You can go through these mental scores. The more you see, the longer the lesion, the bigger the arc, etc. It doesn't have to be, to the T. But a lot of the times and I'll get to it in a minute, you may want to test with a balloon. So again, you look at the vessel lumen, so you're measuring from what to what now? Anybody, can somebody put it in the chat? What is A showing? It's a measurement from what? Is this lumen edge to edge, or what are we measuring here? Can somebody put it in the chat for me? I really want this to be, okay, she has, Sahib put it, it's EEL. So if you can't, then you go by lumen. Oops, I'm sorry about that. Right, so we go to the next one. And again, this is angle. These are the reverberations that you see over here, these very fine lines that you're seeing. I'll give you a better nodule, so we'll skip that last slide D. So let's look at these cases now. So this is what a calcified nodule looks like on OCT. This is what it looks like on IVUS and the corresponding histopathology. Now, what it is calcium that is protruding into the lumen, but it's actually sitting on a base. The difference between an eruptive nodule and a simple nodule is that the simple nodule is more like stable chronic angina. So it's not active, and it's got a fibrous cap that's intact. Anything where you start to see breaks in the calcium, necrotic core that is seeping in, and so it's actually softer, is an eruptive nodule. Now, with eruptive nodules, you may see that these actually yield, and you may not need atherectomy. In fact, atherectomy may worsen them. So you may want to get a feel for what happens. So look at this example. This is on the left-hand side, panel A and B are eruptive calcium in the proximal RCA. And it usually happens in vessels like the proximal RCA. It's actually the commonest vessel to have nodules, because this is where you end up having torsion. And that's where the buildup ends up happening. So you see an eruptive nodule, so it's very irregular, but when you dilate, you're going to be able to expand your stent nicely. When you look at a non-eruptive nodule, although the patients with eruptive calcified nodules are active, so they're like acute coronary syndromes, and actually their outcomes probably are worse than patients without nodules. A non-eruptive calcified nodule, like this other patient, now these are two separate patients, so C and D are different from A and B. Do you see the difference in C and A? So in A, you see a very irregular surface. In C, it's actually very smooth. So this is your intact fibrous cap. But unfortunately, these don't yield very well. And you can still see the nodule that perhaps not enough modification happened, and it's not as deformable, and what it did is it pushed the stent back in, which you can't appreciate very much with standard coronary angio, and you see it with intravascular imaging. Again, another example where you do see nodule at A and B. This is post-stenting at A prime, B prime, and you do see a relatively well expanded stent, and you see the fractures happening in B before you actually expand them. So this is your nodule at baseline. You see after atherectomy, you smoothed it out, but you also have a fracture around 6, 7 o'clock, at 5, 6 o'clock, and then you have an expanded stent over there. Again, you look at the arc here. This is deeper calcium, and you do see that these are stent, right? Do you see the stent struts? The green are the stent struts. So remember the picture I showed you earlier where you actually saw the calcium in front of the stent closer to the lumen. This is behind the stent. So you know that this is under expansion because of deeper calcium. So now your options are different. So you want something like IVL or what have you to reach below it. And when you do get calcium in a nodule, especially, you're going to get it at the edges of the nodule. This is not a nodule, but this is a calcified segment that after you treat with intravascular lithotripsy, you start to see these cracks. And these are what you want to start seeing, disruption of the calcium that tell you it's going to permit your stent to end up being deployed. So now look at these two images. Who can tell me what's the difference between the left-hand side and the right-hand side? If you can unmute yourself, please do. If you're still unable, and you want
So
to...
it looks like people, so you may get an invitation to be a panelist. I think everyone needs to become a panelist in order to be able to unmute. So if you get a signal that asks you to be panelist, accept it, and then it will allow you to unmute. There's been a comment in the chat, Mervat, from Sahib again saying left is calcium.
Yeah, so they are, but where's the, you see these lines that I'm pointing at right now? These are the stent. And it's neoatherosclerosis because it's in front of the stent what's happening, right? So this is the stent, this is your lumen, and all this thickening neoatherosclerosis is in front of the stent. You look at it over here, it's actually behind the stent struts. So this is deeper calcium. So you've got stent struts over here that you see these shadowing, this is from the stent. And this is your strut, this is your struts right over here. You see the shadowing from the stent struts. But this is the calcium that's actually behind the stent, right? So a balloon alone may not be sufficient to crack what's behind the stent. If it's in front of the stent, a balloon may do it. So you may be looking at something like, yes, IVL or laser or what have you. Yeah, fibrocalcific, thank you, absolutely. Right. So again, looking at this is a patient who had calcified neoatherosclerosis. So plain old balloon angioplasty may not be enough when you're looking at this patient. And again, you see the stent struts over here, and you see the cracks around 6, 7 o'clock once they were dilated. I think you've seen this slide, so I'm going to skip it a little bit, but effectively you need to look at the EEL to decide on your sizing pre-PCI OCT. And if you cannot see it, you're going to go with the lumen and you're going to round up to the nearest stent size. Remember that, because ultimately that's your next step, right? So it's MLD, so morphology, length and diameter. That was diameter, and this is length. So you can see my angiogram over here, and you want to be to the closest to the near normal segment. So you see the intravascular ultrasound and you see the corresponding coronary angiogram with co-registration, right? So I'm going to see if I'm able to maybe move this slowly. And do you think these are areas you want to stop your stent in? Where would you park your stent? Anyone? So you see, you see my marker on the angiogram moving as well with it.
Hopefully people can unmute now. And I think this is a really interesting consideration when thinking about experience with IVUS versus OCT. So if you just pause there, Mervat, the greatest difficulty we have here is in relation to the analysis of the external elastic membrane. So at this point, we can really only see the external elastic membrane from about 4 o'clock, 5 o'clock, around clockwise up to between 9 and 10 o'clock. And then what we have is attenuation related to the plaque across the superior and right lateral aspect of the vessel. So we don't have an assessment of either the vessel size or necessarily the plaque burden. And so that can be quite distracting, but that wouldn't be a happy place to land your stent, because you're landing it into an area which is probably quite prone to dissection due to the lipidic plaque that sits across the superior aspect. But if you scroll, then as you've identified, there's actually a very healthy So the distal end, there's a healthy landing zone. At the proximal end, there isn't really a perfect landing position. So you're going to have to probably accept that position that we've identified, and that can make it then more nuanced in terms of your decision making. So that distal, you've got nice example of a relatively healthy, just some pathological intimal thickening, really evident there, the distal end. And obviously you've got caliber shifting from a large caliber proximal vessel, albeit with that disease in addition, but actually a relatively healthy but smaller lumen diameter distal. So you'd size to the distal lumen, and hopefully that would reduce your chance of causing injury at the proximal end. But you would probably only size to the lumen at the proximal end for the purpose of sizing. So it's suggesting a 3.0 mean diameter, 3.02, you can see on the lumen profile, is probably what you're going to be using for the post dilatation. Yeah, so say you're asking about where to land proximally. I think there's always a trade-off. So you have to land into that segment which is not necessarily healthy, but you just have to then accept, kind of take some degree of caution around anticipating that lipid might be prone to dissection, which is where I think you trade off this decision about sizing to the external elastic lamina against sizing to the lumen. And here you would be cautious in sizing to the lumen.
So yeah, I don't know why my computer decided to turn this into. This is an important slide, which is what Tom was trying to describe in the previous run that I was just showing you. So you see, this is normal, and so this is ideal, and at least as close to normal as you can, and this is where you want to be parking your landing zone, either proximally or distally in a vessel, where you want to park your stent. And then there's fibrous, which is the closest to normal that you want with the least likely damage. Then there's calcium, and you do recognize the calcium here, right? So we're seeing calcium from around 11 to 5 o'clock or so. And then you see the lipidic, which is this last one over here, and this is the least ideal. And this is the area where, as he mentioned, dissections, restenosis, peri-PCI-MIs, because of the edge dissections and all of that can happen. And so this is the least suitable, is the lipidic, right? Although some of the more stubborn ones are the calcified and occasionally the fibrous, but actually the lipidic are probably the ugliest place to leave them. So let's look at this case real quickly together, right? So this is areocranial, this is your LAD. You do see a focal lesion over here. Stop me if you can't see or if I'm just running too fast. So angiographically, you don't really appreciate much, right? I wouldn't have said there's calcium there, honestly. Then you put it to a test. You bring the balloon to pre-dilate, and you do see that it's not yielding. There's a very focal segment over here that's actually not yielding. So now you know that it's not expanding, although you're going at higher pressures. So what do you think the most likely corresponding image for that one is? Do you think it's A, B, or C, folks? Which one do you think it is? Don't worry about it. We're all learning together. So I'm seeing most people are saying C, that it's, and what are you seeing in C? What's happening here? Okay.
Computer's still not unmute.
I'm not sure, honestly, but it is calcium, correct. So it is calcium and it is C, and you do see that from you have a tiny dissection there. But this is what you do see. So angiography will underestimate the degree of calcification. We need to be very vigilant when we're looking at balloon to look at, uniform expansion of that balloon, because you saw in the image that I showed you that it was really just a very focal segment where it didn't, and that's where we got the hint that there was calcification. So the OCT run is actually showing you just that. So you're seeing your concentric calcification. You're seeing around 6 o'clock over here in this one. The controlled dissection that we have, you see your calcification running from around 9 o'clock to 5 o'clock. Again, deep calcium, and you see the distal dissections over there. And of course, you're still looking at your severe calcification. It's more than 180 degrees. It's more than 0.5 in thickness. It is a long segment and not just the focal as the balloon suggested. And so this is a significantly calcified segment. And this is exactly what it looks like when you're following it from proximal to distal, okay? Right, so shockwave lithotripsy, post-lithotripsy, you see the angiogram, and then what do you see here? Who wants to interpret this? What are we seeing, folks? If you can't unmute, so I think, North, you're asking, do you still round up in stent size? Yeah, well, if you're seeing the EEL, then you don't round up. With calcium, it becomes very difficult to find the EEL. And then these are the cracks, correct. So this is the cracks that you're seeing in the middle screen. You're seeing the crack at 3 and 9 o'clock. In the right-hand screen image, you're seeing it around 9 and then 6 o'clock. And at 3 o'clock in the first one on the left, you see that this has gone a little beyond a crack, right? So this is a perforation. It's very deep. Look at how far it's gone. So multiple fractures, but yes, there is some perforation. So I think this has given you quite the overview. I'm going to stop sharing here. And I think we have some nice cases that now we need to go over. And I think Dr. Tom, I think you have a bunch of them. And I think
I've got a number of cases. Yeah, it'd be really nice to try and sort the audio because it will make it more interactive. I don't know whether someone from Red Sand or Alia can do anything to correct that now.
while Tom is loading, do you think we can sort out the unmute business? Because honestly, talking permitted. It says permitted. So can you talk? I'm sorry, guys. I see.
Are you able to unmute? If not, then tell us so that we can try and rectify it.
Yeah, I think you can. Sahib, sorry. Yeah, I think I see his mic is unmuted. Okay, good.
Can we hear you? Do you want to just, so we can hear you? Would be lovely.
Hi, good evening. How are you, everybody?
Perfect. Hey, we can hear someone.
Yeah, wasn't working earlier. Oh, thanks.
Okay, good. Right.
I'm glad
so
to put smiles on your faces.
Sahib,
Yeah.
it might only be you now interacting, so you've now fallen into the trap. But we're going to share the cases. But
Don't
can
worry,
other
I
people
won't fall.
unmute? It would be lovely to hear your voices.
It's okay. Thank you.
So conscious of the feedback from last time that we need to share more cases, I've put together lots of cases. I'd started actually because we'd said morphology, lipid and calcium with a lipid case, but why don't we shift to a calcium case first? So let me go to one that actually that has some interesting considerations. Actually, I'll show you this one first, which is one which I messed up. Just hide people's faces. So this is a case of 57-year-old lady who'd actually presented through our chest pain service with predominant symptoms of breathlessness on exertion. Hypertensive, very, very significant lipids, so a total cholesterol of 9.2, suggesting a familial hypercholesterolemia. And as is actually the case in most of our rapid access chest pain cases, actually, she underwent a CT before coming to cath lab. And the reason for emphasizing that is I think that actually the CT provides for us some really important information that sometimes we are at risk of overlooking. And actually, in this case, I hadn't looked at her CT scan before undertaking the angio. I'd simply just seen the written report. So she had coronary arteries that were reportedly arising from a normal position with a normal course with a mixed morphology plaque in the mid-LAD, immediately distal to the first diagonal with the suspicion of a very significant diameter stenosis. Just check. Please, Mervat, interrupt me if there are things that come up on the chat because it's difficult to see that in combination. But actually interesting, the verbal report was that the calcium grade, so the overall burden of calcium on the CT scan was mild. So this was her diagnostic angiogram. So we see a dominant right coronary with really very little in the way of obvious angiographic atheroma. And then from this spider projection, we see a circumflex, again, relatively free of disease, and just the suspicion in that iliocaudal projection of maybe something associated with the diagonal branch. Actually, when we look at the cranial projections, then we see an interesting anatomy of this very, very large, what appears to be a septal rather than true LAD, with this bifurcating pattern within the septal, with disease that extends across the LAD septal bifurcation. And so actually we then see that there appears to be disease extending up into this. I've actually thought this to be LAD and this to be the septal, so the into the kind of LAD, which I think in the CT was reported as a diagonal branch. So I don't know whether people have comment on this angiographic appearance. So we'd actually recruited this lady to a trial that we're participating in, and is a really interesting one around the use of drug-coated balloon in de novo disease. And I have to say that actually at this point, I was kind of hoping that she was going to recruit into the drug-coated balloon arm, because I wasn't clear about how this bifurcation was going to behave with stenting. But actually, she recruited into the stent arm of the study. So I undertook an OCT evaluation, so into what I'm calling the LAD, although some people might argue that this is an odd anatomy. And actually what's important then is, as we scroll back through the LAD, you'll have seen on this lumen profile a fairly significant degree of atheroma if I pause and scroll back. So we can actually see really quite high burden disease. So there's the bifurcation. So going off at 2 or 3 o'clock is the septal, this large septal branch down here. And then as we come more distally, what you then see is actually this, we start to lose any of the signal of the deeper vessel structures. And that's a really important characteristic to focus upon, because that is evidence of lipid. But if you remember, the CT scan had suggested that there was discrete calcium in this area. And one of the differentials, Mervat showed a nice comparison of IVUS images against OCT images, is that actually IVUS will detect more calcium because it can detect calcium that's deep to lipidic tissue. So here we are losing the signal into the deeper structures of the vessel because the lipid absorbs all of the light. But there's potentially, as we know from the CT, fairly significant calcium lurking behind this lipidic tissue here, which might become a problem when we come to deploy a stent. And then actually we then come out into an incredibly healthy artery. So here we actually have a very nice, when we were thinking about landing zones, we can see here actually that we have really very healthy artery. You can see the nice black medial band. We can make a measurement of this vessel size dependent on the EEL. So we can see it's probably in the order of about 2.5 to 2.75 millimeters. And then as we come up, we see that lipid, and then we come up into the larger caliber proximal LAD, and then actually we come into more high burden disease. And as can be quite challenging with the imaging now, is that we don't really see anywhere that's going to be potentially healthy for landing. We see this segment of healthy vessel, but actually, again, lots and lots of disease associated with this plaque. And so the landing, Sahib, you asked in the previous presentation about where to land. It becomes incredibly challenging. And in fact, you might look to try and land this relatively short. Now, I'll sometimes use this lumen profile contour as a useful kind of assessment of where's going to be safe. It's much easier to do when you also have the lumen area apparent, which on this recording I can't share with you. But we see here then a lumen area, a tight lumen area at this point, and further disease. So I predilated, and so now we can see predilatation has been undertaken, and we then start to see this disruption And actually, we do see some evidence of calcium. So if I just, again, come back, we can see here a little nodule of calcium discretely demonstrated. And actually, as you often will see when you predilate, you see then areas of dissection and injury that tend to occur at the shoulder points of plaque. So we can see that here. And then that nodule of calcium is apparent underneath, which is relatively minor nodule of calcium. Here's the wire that is placed into that septal branch. So you can see that coming at 11 o'clock. And then upstream, you can see actually now we have a much better opacification of the lumen, and we can see here actually a healthy landing zone with a measurement that's been made of 3.5 to the lumen and probably just over 4 millimeters to the EEL. And then you might notice that on this longitudinal, I've made a length measurement. And the reason for making that is to really anticipate where the bifurcation comes off. So we see that that's telling us that I'm going to have a long enough length to undertake a proximal optimization of the bifurcation, ensuring that we overcome this discrepancy in the proximal size, which is larger, to the distal size, which luminally is measuring 2.75. And here we see that injury, and what we can't necessarily appreciate is that potentially some of this calcium might extend and become actually higher burden, but is obscured by the lipid. So I deploy the stent, a 2x24, undertake the 3.5 millimeter pot, which you can see there, placed to the carina of the bifurcation, and then post-dilate. And this is the immediate angiographic result, where actually we have quite substantial pinching. Sorry, it's slightly granular, but pinching of the septal branch. So I recross and kiss, and then that's the result, which kind of looks all right angiographically. There's a little bit of restriction at the level of the distal main vessel, but angiographically, I think it's kind of acceptable. And then the problem is you do the OCT run, and actually what we see here on the lumen profile very clearly is this kind of hourglassing, significant underexpansion of the vessel at the level of the bifurcation. So on the longitudinal here, you can just see the wire coming into that septal branch, but you then see this incredibly eccentric lumen and ongoing restriction. And so that really was quite disheartening, I have to say, having gone about doing this in a MLD max approach of looking at the morphology, trying to anticipate the problems. This came out as being a little bit unfair, it felt. So you can see here that we actually have a minimal stent area at this point of 4.05 millimeters squared. And so suggesting, though we shouldn't really be assessing this to the proximal reference in terms of this expansion index, it's probably more appropriate to consider it in relation to the distal area, because we're beyond this bifurcation point, but it's still in the order of about 60% expansion, 60 to 70% expansion. So what would people do here? Anyone offer their thoughts or wise words?
I guess post-dilatation in that area would be very beneficial.
Further post-dilatation. Yeah, so
Yeah.
I mean, I think going to higher pressures, potentially higher pressures rather than larger balloons. So again, it's always important to come back and to make assessments of the sizing of the vessel. So we can see here actually that this artery distal to the stent is actually quite large. It's probably in the order of about 3 millimeters. So taking a 3.0 non-compliant balloon, potentially re-kissing so that we retain the geometry of the bifurcation is very reasonable. And then you said if it's calcium IVL, yeah, I think, I mean, obviously it's not licensed intrastent, but I think absolutely that is a possibility. I think the difficulty is we don't see that I mean, I guess the question is this just calcium that's restraining the stent, or is it down to also to burden of disease? And I think that's a difficult one to consider. But at the moment, I think we all agree that 4.0 as the MSA in what's a 3 millimeter vessel is not sufficient. So we go back, I actually went back with a 3.5 millimeter balloon, so felt that I could probably go higher than the 3.0 of the distal, and so took a short 3.5 balloon to high pressure in an attempt to get this further expanded. And you can see now with this final OCT run that we've taken the MSA from 4 to 4.6. So that actually has given us greater expansion. We still see this highly eccentric stent, which is far from perfect. I guess the question is, how far do we push this before we cause injury that's going to put the patient at even greater risk? So perforating the vessel, I guess, would be the greatest concern. So actually, I accepted this having reached a threshold of 4.5, albeit it not necessarily being as good as I would have hoped. But that was one of I think a combination of high burden lipid and calcium causing a potential restraint. So let's move on.
If you don't mind, if I ask a question here.
Yeah, of course.
Probably it's not related that much to this particular case, but talking in general, and I did ask this question previously, in terms of comparing the IVUS data that we have when we do the MLA with IVUS compared to the OCT. I know we are looking at two different things, but as you know, with the proximal vessels, if it's below 4 in IVUS, 4 millimeter squares, you will call it significant.
Yeah.
And you will go and do something about it in terms of revascularization or whatever. What about if you check the same vessel where you had below 4.0 square millimeter, say you had a 3.5 by IVUS? What would you expect that segment to be in OCT? The same?
Yeah, no, so they do give different measurements. So there's an incremental increase in size dependent on using QCA or visual estimation of the angiogram against the OCT against the IVUS. It's about a 10% increment in terms of size that the IVUS will potentially overestimate. It's felt that OCT probably gives the most accurate representation of the vessel size. There's about a 10% difference between the two. But I think it is very important to understand that they give different outputs.
Absolutely. So what you're saying is that if you have a 4 millimeter squares in IVUS, it's actually 3.6 in OCT.
Yeah, so when you're using the metric of 4, I don't know whether is that in relation to a significant left main area or...
No, I'm talking about significant proximal LAD. Left main, you know, is 6.
Yeah. So I mean, I think that's
take any random number. If you have a 6 millimeter or 5 millimeters in IVUS,
yeah,
does it mean
that
area is 4.5 in OCT or is 5.5?
So you're talking a diameter, not an area, or yeah? So the diameter of the vessel.
I'm talking MLA, diameter.
MLA, okay. So yeah, so it's about a 10% increment in size that we see between the IVUS and the OCT, with the IVUS being the larger number. So that in many ways is represented by the difference that we had in the original consensus around the optimization areas we should be trying to achieve. So we suggested a threshold of 4.5 millimeters squared by OCT and 5.5 millimeters squared by IVUS. Now, actually, there's some important slides to consider. I'll show you a couple of slides in relation to that in a moment. What was interesting was to go back and to reflect on the CT. So this is looking at her cross-sectional imaging of her CT, where we see this very, very high burden, but discrete calcium in that area where we had the significant underexpansion. And I have to say, it was only on reflection after the case that I looked at these images, and I think it highlights the importance of potentially using the imaging up front to try and do that. Now, Sahib, in direct response to your question about this understanding of the areas and diameters, I think it's really important because a lot is placed on our understanding of where we should be in terms of optimization. And I have a slight anxiety around that because using an absolute metric, an absolute number for optimization is we have to be cautious about because it doesn't reflect all cases, all arteries.
Couldn't agree more.
And one of the problems we have then is that, you know, we work between, oddly, choosing our stents by diameter and then optimizing them by area, which is quite nonsensical, really. So if we think what 4.5 millimeters squared equates to in a perfect circular area, it's actually a vessel diameter of just about 2.4 millimeters. So actually, if we've deployed a 2.5 millimeter stent and we're left with a vessel that's just slightly underexpanded, so less than 10% under expansion, we'll achieve a decent area. Now for IVUS, and this highlights this differential in terms of the sizes that the IVUS and the OCT give. If we use the 5 millimeter square cutoff that was used for the ultimate study, then we're looking at a diameter difference of 2.4 against 2.5. So it's really relatively limited. And so when we come to place, you know, a perfect 2.5 millimeter stent into an artery, we're talking about a diameter stenosis that's less than 5% and an area stenosis that's less than 10%. But then it becomes more important to understand that when we consider the disease or the vessels that we're treating. So if we're going into a very, very small artery, only 2 millimeter artery, then actually we shouldn't be expecting our stent area to get any more than 3.1 millimeters squared. So striving for 4.5 in the setting of a small vessel risks us generating too much injury. And then the opposite is true when we start to think about larger vessels. And so I worry that people might use this absolute metric of 4.5 in an artery that actually should be substantially larger. So a 3 millimeter diameter equates to an area of 7.1 and a 4 millimeter of 12.6. And so actually these absolute cutoffs of 4.5 or 5 by IVUS really massively undercook what we should be trying to achieve. And I've been pushing actually for Abbott and other vendors to start putting the areas on the stent boxes along with the diameters. We should start to have more familiarity with these numbers that we should be trying to achieve for different vessel diameter sizes. But I think that's quite an important consideration. Let me share one more calcium case, and then we'll see. I think there may be one colleague who's got a case that we were going to share, and then we can look at 2 or 3 more cases from Mervat, myself, Mogni. So this is an interesting one in terms of pushing the envelope in terms of calcium adaptation, modification. So this is a challenging right coronary that actually has been previously failed by a colleague. And so the patient has been brought back electively for treatment of this right coronary. So I don't know if people want to think up front about how they might approach this before I show you what we did. But we know that this was a previously uncrossable lesion. You can see that we've actually prepped this. This is a 7 French AL 0.75 guide catheter. So we've gone up front with a fairly aggressive guide catheter. I don't know whether people have any comment about how they'd like to approach this vessel. So it had been wire crossable, but they were unable to deliver a balloon.
It's about ablation case.
Yeah. So certainly I think it is a case of debulking, whether that's rotablation or orbital. I guess you could consider either. So this was, I mean, I think the reason for we're far more familiar with the use of rotational atherectomy, but we've been developing our experience with orbital, and so that was probably the reason for selecting orbital over rotational atherectomy for this specific case. But I think they are potentially interchangeable in this particular example. So I don't know whether you guys have much familiarity with orbital. Certainly I know at Gulf PCR 2 or 3 years ago it was being promoted, so is available in region. We we deployed here at the slower speed and did multiple passes and actually did about 10 passes. And there was particular restriction. You can see it actually passing relatively rapidly at that point across this tight lesion. So where we're seeing the greatest restriction is around this area of tortuosity and relatively a significant angiographic stenosis. And actually, there's a fair amount of momentum that's built up on this because it's meant to pass very slowly, and you see it suddenly shoot across this lesion just as we allow it to pass through. So that's not best technique. But we actually focused our attention really on this area where there had been significant restriction. And then what's really interesting is then to run the imaging. So this was with us using the original Ultron 1.0 software. So this obviously automatically detects the calcium. You can see I'm just reducing the sensitivity to highlight areas in the longitudinal where we see greater than 180 degrees of calcium. And what you can see on the short axis is these orange bars are signifying where we see the arcs of calcium. And then along this longitudinal approach, we can see where we have the length of calcium depicted in orange. And so we can see actually that we have, in terms of the rule of fives, we've got an extent of greater than 5 millimeters in length. We have an arc that exceeds 180 degrees, exceeds 50% of the entire vessel. And actually, if we go and make a measurement of thickness, you can see that the Ultron software very cleverly actually makes a measurement of the calcium thickness, which is exceeding the 0.5 millimeter, half a millimeter thickness. So actually, we have all of the potential drivers for predicting stent under expansion. And I think the other interesting thing here is to see how that interaction of the orbital had actually debulked and modified the very high burden calcium. And actually, I have to say, concerningly, really, in some ways, what I saw here was that the burr, rather than taking this circumferential orbit, as I show in this cartoon, instead, what it appears to have done is kind of bury itself into a channel. So it was actually just making its way out of the vessel. You see this beautiful circumscribed debulking area of where the orbital device has interacted with the calcium. So I don't know what people might want to do from this point onwards. So if I could share with you the angiogram again. So this is how the angiogram looked. And you've seen the OCT. What would be people's next step? Any comments? Anything in the chat?
I think I will have to go for a proper pre-dilatation for this.
So what do you mean by proper pre-dilatation?
You have to debulk this calcium again, I think.
Do what, sorry?
For some calcium debulking techniques, more than the orbital atherectomy.
So take rotational atherectomy now, or
rotation?
Okay.
Rotational atherectomy might be a good option for this.
Yeah, I mean, equally, we could go back with the orbital, but I think the concern here is that we're not seeing the orbital take a true orbit. It potentially risks, I guess, burying and just further debulking into the deeper wall structures. Is there another chat? IVL, New Wonders. Yeah, Adele both wonder about IVL. So I have to say, from a cost perspective, initially, I did just wonder about ballooning, as someone mentioned up front. So this is where the algorithms, I think, struggle. But the important thing here is recognizing. So we recognized this is the algorithm that's very pretty, generated by James Spratt and Margaret McIntaggart in collaboration with Optima. We went down this path of showing significant arc greater than 180 degrees with significant thickness, and it was suggesting using intravascular lithotripsy. Now, actually, we've used orbital to debulk, but I think the most important step of this algorithm is that you use imaging at the front end, and you then also use it after having deployed your modification tool to assess whether you've done enough modification. And I think, as all of you have recognized very appropriately, there hasn't been enough modification yet for the purpose of stenting. And so whether you go back and you just balloon with a non-compliant balloon, or use lithotripsy, or potentially, as you said, further debulk with either the same or a different device, is I guess, a kind of learning curve. So this was a 3.5 NC balloon, and actually we saw wasting in that area of high burden calcium. So I then went on and took a 4.0 intravascular lithotripsy balloon. This was the original kind of 80 pulse balloon. You can see that being deployed again with some still persisting restriction. And in actual fact, the balloon burst. So here I've captured the fluoro image of the IVL balloon bursting after, I think, around 60 or 70 pulses of delivery to the vessel. So at this point, actually, and again, this I think is the important element of any of the algorithms, is that once you've performed some modification, that you really want to know what the vessel looks like before you consider stenting, because as soon as you've stented, you can't take it back. And the concern would be that still there is a risk of stent under expansion. And so I think what's interesting then is to look at these images. And as Mervat highlighted in her case examples, we do see really quite extensive injury. So you see this contrast certainly into deeper wall structures. Now, whether that is, I think that still remains within the vessel architecture rather than passing through the medial layer. I think the media you might just see evident here, and probably extends around outside the area of dissection. It's less clear at the kind of 7-8 o'clock fracture point, but again, I would anticipate that the outer boundary of the vessel might be slightly more deep. And certainly then from an angiographic perspective, see, the concern might be with the injection of contrast, but actually these vessels remain remarkably stable. And we can see that we've generated significant adaptation of that very high burden calcium that was evident before. Although more concerningly, you see that the device, the OCT and the wire, seem to be kind of out on the very outer curvature of the vessel, maybe outside what was true lumen. And we see again extensive injury with these areas of tissue dissection and the calcific segments also evident. And then these are the very classical kind of fracture points of the IVL, that we can see these kind of punched out areas within the calcium that are clear. And I think then what's interesting is that area where the orbital had clearly made its channel and was of around about the 1.5 millimeter dimension of the burr, you can see that with the further ballooning and IVL that we've significantly adapted that. So opened that from 1.5, 1.6 millimeters up to 2 and 2.3 millimeters. So hopefully then allowing then for better expansion of our stent moving forwards. So then went on and stented around this area of very high burden calcium, and then due to the extensive injury that we noted, we stented back to the ostium of the vessel. And then importantly, we see here then the repeat OCT run showing us this slightly irregular luminal area contour, but actually with very effective stent areas. So I mentioned that we deployed 4 millimeter diameter stents, so we should be expecting an area up to around 12 millimeters squared. And so clearly this isn't as large as you might expect a 4 millimeter stent, but it still is achieving a very large vessel area. So I can see there's something in the chat.
Yeah, so I think they're asking you, when you see this much dissection, are you still comfortable with OCT?
Yeah, honestly, yes. I think calcific disease is very different in the sense that we're actually trying to get dissection, and we're trying to create vessel injury for the purpose of optimizing the ability to expand a stent. There's a lot of talk. Everyone's talking about enhancing vessel compliance, and that's only achievable by creating lots of injury. So I think that is something that we can expect, and actually it behaves in a very stable fashion. So I don't have major concerns with using OCT in that setting. And I actually like the detail that I get from OCT over IVUS for these types of cases. clearly where you have vessel injury and holdup of contrast or concerns around having had iatrogenic dissection of a vessel and you don't want to propagate dissection down vessel, then that absolutely is somewhere where you would avoid considering the use of OCT. But in this case, no concerns at all.
Just one question, Tom,
Yeah.
please. In the OST run just before you deployed the stent, any particular clue that stent will deploy will expand or just that cracks and the calcium modification that were obvious in this run?
Yeah, I mean, I think that's a really good question. I don't think we know precisely. So this issue around the idea of enhancing vessel compliance, I think you have to use a combination of the angiographic appearance of how your balloons behave and then the information you get from the imaging. So if you take this cross section as an example, you've got a plate of calcium and we have effectively cracked that horseshoe of calcium at this point here. And again, we have really quite extreme injury around this area of more elastic, slightly healthier tissue. There's a very, very fine rim probably of calcium. So this was concentric, but as you might expect from a mechanical perspective, a point of weakness is going to be this thin into thicker plate calcium. And then the Japanese actually have shown beautifully in their kind of series OCT imaging that there's actually when you hit a level of concentricity of calcium that exceeds 280 degrees, so once you get a proper horseshoe, they actually anticipate that a non-compliant balloon will effectively fracture the calcium, because what you end up doing is the two wings of the calcium get brought outwards, and you then classically see a fracture point at the apex of the calcium, which is sort of what we see here. You see that you've got a fracture point, which is kind of at the base and at the base of these two outer curvatures of calcium. Now I actually see additional fracture here, and obviously we've taken IVL in addition to standard balloons. So the hope would be that we've created quite a lot of fracture points, which means then that hopefully when we come to deploy a stent, we see that open up. But I think from an academic perspective, an interesting thing to explore is whether actually avoiding stenting in some of these cases, particularly in the very protrusive eruptive nodule disease, it might be that we should think about using drug-coated balloon and avoiding stenting altogether. Merva alluded to that in her presentation.
Yeah, so I think there's a lot of suggestion, particularly with intravascular lithotripsy, that you achieve more than the visible fissures or cracks, that there's finer, just a little bit like what you showed in the other frame at 3 o'clock, those really fine threads of cracks that are sometimes not visible. And I think with a lot of refinement now, they're starting to see it. I'm going to pull up an interesting slide while you finish your case.
So I was going to. So I've got the slides around this eruptive calcified nodule. I don't know whether that was what you were going to show, Mervat, which an interesting case series around identifying this type of disease, which is important, I think. And as actually, this is data that's come from Renu Vamani and from the Disrupt CAD series, and has kind of really shifted certainly the way I thought about this, because that protruding nodule of calcium that Mervat showed where the stent expands, but you get areas of malapposition because the vessel doesn't yield, I had always been most troubled by. But actually what's been interesting from this is a post-mortem series of Renu Vamani's, but then also shown in the Disrupt CAD group work, that these eruptive nodules are the ones we probably ought to worry about most in the long term. Now, what's really interesting from the histology of this is that you see that you've got these kind of, it's almost like a rock garden of this kind of granular type calcification, which is actually embedded within lipidic necrotic core plaque. And what they've noted from these series, both post-mortem and then in the clinical series, is that these eruptive nodules tend to occur around areas of mechanical stress. So particularly in areas where you have significant stress put on the vessel through excessive movement. So the classical kind of mid-right coronary territory, or particularly in the proximal LAD, proximal circumflex. And so that's where these eruptive nodules have been observed most frequently. And the reason that's important to understand is that both you have calcium that is angiographically most apparent at a point of significant stenosis. But if you're not using imaging, what you then are unaware of is that actually the calcium extends both up and downstream and can cause additional procedural problem. And so this is a really nice series of looking at eruptive versus non-eruptive calcified nodule. So looking for these OCT appearances of this kind of craggy, irregular surfaced eruptive nodule against that smooth protrusion. And I have to say, I'd always been most concerned about this smooth protrusive disease, where I worry that you deploy your stent and then you don't get adequate expansion. And certainly that's what this series showed, is that in the setting of comparing eruptive against non-eruptive, that the stent expansion achieved in these protruding smooth nodules was less. So stent expansion in the series was around 80% with the non-eruptive and about 90% with the eruptive calcific nodule. But more concerningly, actually, is that in the long term, it turns out that actually the event rates in the eruptive nodule group was significantly higher. So this is a relatively small series of just over 200 patients, but you can see actually that out to 2 years, the risk of target lesion failure is really very high. It's 20%. And the kind of hypothesis around this is that the reason you have this eruptive characteristic of the calcium is because it's on this area of mechanical stress, and that actually you then place the stented segment under that same stress long term, so that we then see this re-eruption, this fracturing of the stent and re-protrusion of calcium that develops in those areas. So I think actually both eruptive and non-eruptive pose problems, but different. So in the short term, we worry about how we're actually going to get a stent to expand and behave and oppose in the non-eruptive nodule. But I think we then also need to worry in the long term about the risk of stent fracture and reprotrusion of calcium with the eruptive nodule. So it's been quite an interesting kind of observation made by more contemporary studies. So I don't know if that's what you're going to show, Mervat, or you want to share something else.
And the idea is that in addition to that, eruptive probably represents an active process happening. So something similar to acute coronary syndrome compared with a chronic coronary syndrome. So if you have an event, the outcomes over time it's very similar. But when you're done, I don't want to disrupt your presentation.
No. I can stop there for now, and let me stop sharing.
Something really quick, and then you can pop right back, just so that we're on the same page. So you know, these are slides that I'm supposed to be presenting next week, or this week actually. Can you see my slides?
Yep.
So the idea is when you're using atherectomy, you're actually, what you're doing is you're shaving off. But with IVL, in fact, what you are doing is creating cracks. So you see that? So the cracks that you see, this is what IVL presumably does in calcium. And then just a quick point that we kind of need to keep in mind is a little bit of what you were saying here, just to kind of re-emphasize the point. Yeah. So if you see this one, so there are two really different types of deformable and non-deformable. The deformable is when you do have something like pre-IVL, and you have soft, you don't know what's behind this protruding calcium. When you look behind it over here, you see soft plaque with necrotic tissue and lipidic. And so when you do create fractures here, your stent is going to oppose nicely. But when you have calcium on calcium, so something like this, that it's not deformable, so it's, you don't see an eruptive nodule. What you do see is a protruding nodule, but actually sitting on more calcium. Even when you fracture it, your stent may not yield because it's not sitting on a soft base like the one that you're seeing here. So this is a soft necrotic. So not all nodules are the same. It's sitting on a jelly-like, soft necrotic lipidic base, and so it's going to yield. This one, it's not. It's still sitting on a rock. So you can fracture it, but you're not going to get a lot of yield behind it. And these are the two differences. So this is one, and a lot of the times when you treat here at the fissure points. So when you're using a non-compliant balloon or a cutting balloon, likely this is where it's going to start yielding, right over here, where you see my cursor is, here and here. The softer it is inside, the more likely when you expand the balloon it's going to work. The harder it is over here, the less likely it's going to expand, and you're going to have fissures only here, but the stent itself is not going to expand. And just as we're wrapping up, there's one last thing that I think we need to be cognizant of, and I just want to show you this. Yeah. Answering the question that somebody just posed about, okay, after you treat, what do you do? One trick is to look at the coronary angiogram itself, and you look at the wire in relationship to the artery in the balloon. So here, you're seeing where this is, right? So if the wire is centered and you've displaced your calcium, this is your calcium up here, this is your balloon, and this is the calcium, you've displaced it, you know your balloon has expanded, and your wire is central to the balloon itself, likely things are okay. As opposed to this next one, look at the wire. So I'm sorry, this is not playing, but that's okay. Look at my wire. And you see that the calcium that is displaced, it's right next to the wire. The wire is not centered. You actually have this dog boning. This is the picture, and this is going to tell you that it's likely not going to yield. So I think those were the most important 2 points that I wanted, because they kind of bring home the points that were mentioned by some of our attendees. Mokun, I think this is a good time to ask you if you had anything you wanted to say, because I know we've kind of dominated the time here.
No, thank you very much. It was actually very informative presentations. Just I want to emphasize that the calcium, actually, it's really underestimated by angiogram. If you have any suspicion, please do intravascular imaging, either IVUS or OCT, because that it will guide you how you will deal with that calcium. Most of the time that you will take it just easy, predilate with sized balloon, then you will put a stent and you will be in trouble. So calcium, I think it's the most important topic in the intravascular imaging, because it will really guide us how to deal with this type of plaque. The only question here, maybe we didn't answer in the chat, that how would you deal with an underexpanded stent under a nodule that was not modified properly? So either acutely or chronic. For example, it's underexpanded and then the patient came back to you. Wouldn't have actually much for me. I'll try IVL. Also in the fresh stent, it's not approved, but I'll try that. Maybe OPN, high pressure balloon. I'm not sure about you, Tom, Mervet.
Yeah, and laser sometimes works to penetrate a little bit beyond, but again, we don't know what that does to the drug-eluting stent, but if it's chronic, the drug elution is pretty much complete, and so has the resorption of the, but I don't think, I mean, really chronic, there are some reports on using rotablator to disrupt the stent itself, and then try to balloon and so on, but I think that's a little too cowboyish for me. But I would consider IVL in this day and age, and I would consider laser atherectomy.
Yeah, I think it's reasonable.
Yeah, what do you
Adele
think,
says
like,
laser with contrast. I mean,
the
I think
structure
there's a
itself?
risk of creating excessive injury, isn't there, and actually undoing your result. It's all been great discussion, though. Do you want me to finish with a different morphology? Should we finish with a lipid?
Shall we do that, guys?
May I ask one question, please, before we
Of
move
course.
on? Was like Mirvat, you mentioned marble on jelly, marble on rock. Was there? I might have missed it with my kids around. Was there any hint in the OCT to actually tell you whether it's a marble on jelly or a marble on rock? Because I think that if I can see any hints, maybe this will change my strategy, and I would consider maybe two modifying devices like atherectomy plus IVL to hit both, or
So the problem with calcium, especially dense calcium, you don't see behind it. And the base is what you don't see. So you definitely don't see it on IVUS, and occasionally you don't see it on OCT either. So sometimes what you may need to do is test it, right, with a balloon and see how it behaves. But just as a general rule, an eruptive calcium nodule generally means you've had cracks in the base of the calcium and necrotic core that's seeped in, and so it's more likely to break like broken glass and to yield than a non-eruptive calcium nodule. So a non-eruptive calcium nodule is actually going to be a lot more stubborn compared to eruptive in terms of yielding.
But I think if you touch upon a really important point there is about how you use multiple modalities, and I don't think any of us know yet. The question around what should we be debulking with rotation atherectomy, orbital, or perhaps laser, and how much is just about fracturing and increasing the compliance. Now, the images that Optima and I have to say Shockwave generate are delightful from a marketing perspective of just saying Shockwave is the way we must go. But I don't think that necessarily tells the whole truth. Shockwave is undoubtedly the most easy of the adjunctive tools to use, the safest to use, and so from that purpose is going to be probably hitting everyone's cath labs more than any other modality. But I still feel that probably a combination of debulking and increasing vessel compliance is going to be the way of getting best results in the most challenging calcium. But we're all
I
learning.
don't know how good is it with nodular calcium. As far as I know, it's not so good. IVL and nodular
IVL.
calcium. Yeah.
Yeah, well, the messaging coming from Shockwave seems to vary, having initially said it had to be concentric to magnify the wave, and then actually it is impactful in the setting of eccentric calcium. I mean, I think it is a very effective technology, but I think we're faced with the most challenging disease where potentially we don't get good results regardless of the technologies we use. And the bit I'm most interested about is where we can actually avoid deploying a stent altogether, which is what we're learning in de novo DCB studies.
Yeah, and so you may need to use combination of therapies. So you may need to do a little bit of paving with either orbital, and orbital says that they're probably some of the best because it orbits. It's not like rotablator where you're defined, but if you increase the RPM with orbital, presumably you get a bigger arc or a bigger orbit, and so you can achieve a bit more. But I mean, at the end of the day, you still have to look at the diameter of the crown or the burr.
Yeah.
But my takeaway would be image. So if you did any modification, whether it's with the balloon or IVL or what have you, image and see how much you've achieved in terms of debulking and modification before you move to another device. But in stubborn nodules, you may need more, and you may in fact need to just create a bigger, better lumen and avoid stenting, because the danger is stenting and then having stent recoil because of the nodule that you haven't shaved off.
Let me promote a session at SASIS in January that Mogni and I are going to be doing, which is an image-guided calcium session. I'm going to share a case from last week, which is actually IVUS guided, but where we went 1.5 rotational, 2.0 burr, IVL, and sequential steps to try and get an optimal result. So I'm not sure yet that any algorithm tells us precisely how we should be doing it, but after 11 IVUS runs, I got a very nice result. But whether that's actually for real time or whether that's just because I'm sad and haven't got a life, I'm not sure. But come and see it in January, because happily share that case.
If you don't mind, may I just ask a question here? With IVL, what do you expect if you, with a calcified nodule? What do you expect the other side of the vessel, which is healthy? What do you expect is going to happen there? And also, same question, after when you stent and it's under-deployed due to calcium, if you use IVL, what do you expect to happen to the actual stent structure in that spot?
Do you want to take that, Mervat, or I have a...
I mean, you can, if the other side is healthy and you're trying to, IVL is a bit different. So IVL I don't think is going to do much, because you only go up to 4 or 6 bar. So the issue isn't how big the IVL balloon, it's, you know, the shock waves themselves. If it's presumably healthy vessel on the other side, it shouldn't do much. And a lot of your breaks and your tears will happen in the non-healthy side, theoretically. My issue is when we just use non-compliant balloons, high pressure balloons, what ends up happening is you end up yielding on the normal side and even causing tears there, because you are going high pressure. So you are going well beyond 4 and 6 bar, and your calcium rock is stubborn. So you actually end up causing more barotrauma on the contralateral side. So that would be my concern. And that's why in something like nodule, dense calcium, when it's very thick, those are the times that I would consider some kind of modification rather than just high pressure balloon.
Yeah, and then in terms of the disruption with IVL in stent, I don't think anyone knows. The concerns were whether you might disrupt polymer. But I think the reality is if you've got a significantly underexpanded stent, then you're probably better off overcoming that underexpansion. And if you need to, delivering DCB inside or whatever, the reality is that we're probably most mindful of the drug that's on the abluminal, the outer surface of the stent, that will obviously then release into the vessel wall. So I wouldn't worry too much about intrastent IVL therapy. I think it's more important that you overcome the stent under expansion, which will undoubtedly result in later stent failure. But I think the message, again, as both Mogni and Merva have said, is that imaging is probably the way of preventing you getting into that scenario. So you shouldn't really be deploying a stent. I mean, I've shared with you a case example where I did have significant underexpansion despite the fact I'd used the imaging. So I think it still will happen. And then we have to have ways around how we deal with it.
So should we go with another case? I know we focused on calcium because that's the #1 indication to use imaging, but I do think we need to start recognizing other morphologies that imaging is going to pick up. And Tom has a nice.
So I've got a little bit more time, haven't we? I've got 2 different cases, but probably for the purpose of this, just share one. I guess maybe so the guidelines, I think, importantly have been adapted at the ESC this year. You may or may not be aware. What am I doing with my presentation here? Oh God. Excuse me. So let me share this case if I can. I need to exit. Sorry, guys.
So while Tom is picking up his case, just remember, if you have cases that you want to discuss, please send them in early to Alia and the rest of the team, and Muqna, because he can actually coordinate with you. And it's nice if the last session that you guys now walk us through the imaging and the cases and do your interpretation. And remember, it's a small group. It's intentionally a small group, so it's intimate. And thanks, Tom.
So this is just an interesting one. It's an odd presentation, but it just again shows the benefit of imaging, and it may well stimulate some debate. So there are no right or wrong answers here, potentially. So this is a difficult presentation of a patient, 28-year-old male, who actually attends after a road traffic accident, unwell, vomiting, with a with a left wrist fracture. So you have to be questioning what I'm sharing this with you for. He had actually quite a worrisome background, complex history of 6 previous DVTs and an unprovoked pulmonary embolus. And he'd been on apixaban for 3 months preceding this injury, but thankfully had actually, we're not sure why, stopped taking the apixaban before having his road crash. And he was under hematology who were wondering about whether he had some underlying thrombophilic state, and had also undertaken a JAK2 assessment. Now, during this acute presentation through A&E, he underwent a CT that showed actually a new pulmonary embolus, and his ECG, interestingly, demonstrated the classical changes. And then more worryingly, his echo suggested possibly some hypokinesia, and he was found to have a markedly elevated troponin. So everything was happening to this young guy, and nothing really joined up, nothing made sense. On the back of all of this as well, to add insult to injury, he had a significant family history of ischemic heart disease with elevated lipids and multiple deaths on his mother's side under the age of 40. So a ticking time bomb. So this was his ECG, which was quite abnormal. And it had to be said that, this T-wave inversion that we see in the kind of infralateral territory may well have been kind of giving a more ischemic type pattern. So the question would be, well, what next? And so what I really demonstrate now with the next tests, I think, is the knee-jerk response of just ordering test after test after test. But actually, colleagues, I wasn't involved in his care until afterwards, actually, and have just sort of brought this together as an interesting presentation. He underwent a cardiac MRI, and they did this to really understand. The report highlights here that they felt that the ECG was more demonstrative of coronary ischemia, that the echo had shown reasonable left and right ventricular function with no clear-cut regional wall mesh abnormality. And the question that they asked our radiologists were, is there evidence of a paradoxical embolus, so evidence of infarct, and is there any evidence of myocarditis as potentially another reason why this guy had significant troponin elevation? And actually, the MRI was incredibly valuable because it did demonstrate quite significant edema. So we can see here marked edema of the inferior wall. And then importantly, evidence of microvascular obstruction. And so actually the report from our radiologist said the findings were in keeping with an acute myocardial infarction in the right coronary territory. And in the context of his acute PE and previous PE and DVTs, that this was most likely to be embolic in origin. And then most concerningly, that the edema and the transmural nature of this injury, along with the microvascular obstruction, suggested that he was going to sustain quite a large inferior wall transmural infarction. So what next? Any thoughts?
Alaikum assalam.
Sorry?
Yes.
So he had a CT scan next. I don't know quite why he didn't just go for an
It's been
angiogram.
in Prague.
I couldn't hear that, sorry.
Okay.
Okay, so Kath, I can see on the chat. So here is the CT scan. And interesting, sorry, someone might need to go on mute. Interestingly, what we see on the CT is clear evidence of injury in the right coronary. And then oddly, our cardiac radiologists have suggested that this was evidence of a vessel with absent atheroma, but severe disease that seemed to be in keeping with dissection. So now all of a sudden we have a different diagnosis being made by our radiology colleagues. And I have to say, this all didn't quite add up. So he did then go for a coronary angiogram. And so here's then the coronary angiogram. And actually the coronary angiogram is probably the least exciting modality of imaging that we've had. So the MRI was quite striking in terms of the inferior wall myocardial infarction, and the CT clearly showed significant injury. And so actually we went on and imaged this, and this was actually one of my colleagues who I'm impressed with, despite the potential for what was felt to be dissection in the right coronary, has gone on and done an OCT run. And so I just thought it would be interesting to share with you this OCT. And I think this highlights that, the resolution that we get here, 10 micron resolution, gives us then far greater fidelity and an ability to make a diagnosis. And what we see quite clearly here is that this guy has atheromatous disease. Now, it's soft plaque. He's only 28 years old, and potentially that's why then my radiology colleagues have not distinguished this as true atheroma, although I'm not quite clear why not. And so the findings are really quite interesting here, but shows that he's got incredibly diffuse disease. Now, I think the only other thing to emphasize here then is that actually, when you look at the lumen contour, although he has this high burden of fibrotic and fibrolipidic plaque, actually his lumen's relatively well preserved. And so actually, in view of the angiographic appearance and the OCT reassurance, we elected actually to manage this chap conservatively in the first instance without the deployment of any stents. And actually he's done remarkably well. So he was conservatively managed from a point of view of intervention. He was on triple therapy for his pulmonary embolus and evidence of potentially an acute coronary event with this thrombus that we see adherent to the plaque in his right coronary. And he'll then continue with DOAC and clopidogrel for 12 months and DOAC long term. And clearly with his family history and the lipids, then he needs aggressive treatment. He's actually been followed up by a colleague 4 months later, and he's had no further problems, which is good news. And his JAK2, interestingly, was negative, although JAK2 is a marker of potentially aggressive development of coronary disease. And I just thought that case very nicely kind of exemplifies, I think, why the most recent ESC guidance of 2023 has increased our awareness of needing to use intravascular imaging in the setting, specifically of ambiguous angiography, and then also this very nice kind of working schema of where we should be using imaging. And I think predominantly OCT in the setting of acute coronary syndrome, where we particularly don't have a clear culprit. And so trying to understand whether we have erosion, rupture, nodule, spontaneous dissection, or whether actually this is non-coronary, and potentially then we shift to other modalities like MRI to look for evidence of myocarditis or significant inflammation. So I guess this is kind of a nice way of moving towards webinar 3, where maybe we look at other uses of our imaging. We could do a bit on MANOCA if you like. We can look at also the use in bifurcation and things of that sort. But we await your comments on today's webinar. We'd be really keen on some follow-up and feedback if we can.
Thank
So I
you.
don't know whether there are any thoughts there. Salah, I see you say, was there any evidence of plaque disruption? Yes, sorry I skirted over that, but I can very quickly go back, just conscious of time. So in that still frame, you can see here this slight irregularity. The difficulty is that there is some blood swell, although it's relatively well opacified, but there's this irregular and attenuating pattern to the surface of the lumen here, which is very suggestive of red thrombus. And then in addition, you can see this area of more mature thrombus as well, protruding into the lumen on sequential frames. So there was evidence. I think the difficulty we have here is of defining whether this is plaque rupture or erosion. Because we have this attenuation, we can't really see whether there is any disruption of the underlying plaque. So often that's quite difficult for us to potentially assess. But an interesting case.
I mean, that was lovely, Tom. Thank you. I just want to remind our attendees that we only have one more episode coming up in January. Then, as Tom mentioned, during SASIS, we're going to have an entire session on intracoronary imaging, which hopefully is going to show a diversity of cases. But what would be helpful for the next session is if you let us know what you need us to go over. The plan is we're going to go over. So we did morphology, which is pre-PCI. We're going to focus a little bit on post-PCI, so optimization. So how can PCI help you with optimization? And we'll try to keep it case-based like today. But if there's anything else that you want us to touch on, I think it's important that you let us know so we can add it in the next session and build on your needs, really.
Absolutely.
Is there anything you want to let us know today so that we can prepare for the next time? Or if you need to think about it and let us know, that's also okay. But it's an opportunity that Mokhna, Tom, and myself are here now, and we're ready to hear what you need for the last session. We're here for you, so speak up if there's something that you have in mind, please, or something that we weren't very clear and you want us to clarify next time.
Or communicate it via the team and we can get things prepared for January.
So there is some, in the messages, they mentioned that recognizing complication using OCT.
Yeah.
So maybe.
Okay, so I've got a few nice cases of even things like wire fracture that we could look at and how you overcome that, and other things we certainly could look at from a case-based perspective.
Perfect.
Yeah. So I think the plan will be to do post PCI really quickly in the beginning. If you have cases, please send them over so that we can review them and prepare them for the session. And then Tom will cover some complications as well.
Great.
Well, thanks, everybody.
Take care.
Thank you.
Thanks, Mokhna, Mervat.
Bye-bye.
Bye-bye.
Thank you so much.
Thank you.
Thank you so much. Appreciate it.
See you.
There is SCAD and hematoma also, Dr. Mervat.
Okay.
Mentioned in the chat.
Thank you very much. Just nudge me in our group, please, so we remember what to collect for them.
Yes.
Shukran.
Thank you. Shukran, Hazrat.
Thank you all. Bye.